First, I want to thank everyone that's here this afternoon for coming. And I wanted to thank Forest Park Frisco for hosting this. I'm Dr. Ayoola. I'm a bariatric surgeon with weight loss specialist of North Texas. And we're here to talk about health, obesity, and weight loss. And as you've seen in that trailer, that short clip from an HBO documentary, this is a problem that goes far beyond any single person, any community, but it's something that really affects the country as a whole. So I have a question for anyone in the audience. What's a normal weight? What would you say? 50 pounds, 100, 2, 3, 4, 5? Who wants to guess?
200.
200, right. So what if that 200-pounder is a 9-year-old? Is that still a normal weight, right? So you can't just have weight be the only thing you use to characterize if a person has a normal weight or is an appropriate size. So in order to have a good idea of what a normal weight for an individual is, you have to also keep in account what their height is. And when you have this ratio of weight over height, we call that the body mass index. And if you can calculate that in different ways, you can use kilograms over meters squared, or you can use pounds over inches squared, but then you have to multiply that by 703. So I like the first one because it's easier. All right. So when you calculate a BMI, that gives you an idea of what kind of risk a person faces given their weight and height ratio. If you're overweight, you're a low risk person. If you're class 1 obesity, you're moderate risk. Class 2, you have a greater risk, and anything over class 3 is an even higher risk. And those classes are defined by the numbers you see under the BMI category there. Once you go over a BMI of 30, you start meeting the classes of obesity. So when we say risk, what do we mean by that? What do we mean you're at greater risk? Risk of what? So let's see the next slide. So here are some of the things you put yourself at risk for with a higher BMI. There are things like hypertension, diabetes, high cholesterol, stroke, heart attack, and even certain cancers that have been linked to excess weight. And there are other things like migraines, depression, gout, urinary incontinence, and the list goes on and on. And certainly you may not have all of these problems with excess weight, but you're at higher risk, and even at a younger age, if you don't experience some of these problems, as we all get older, the body is less tolerant of the excess weight, and you become even higher risk for having these problems. So the question is, so what if I'm at higher risk? Well, consider some of these numbers. About 70% of the country is overweight or obese. What that translates to is about 400,000 deaths that are preventable every single year. In addition to that, you have 1 out of 6 morbidly obese people will die within the next decade. And I think one of the most alarming numbers is the change in life expectancy. You have an 8 to 13-year drop in your life expectancy just due to the excess weight. I think that anyone would appreciate an extra 13 years of life to watch their children get married, graduate high school, and spend time with their loved ones and things like that. So that's why this matters. There's the founding director at Yale University said, throughout most of human history, calories were scarce and hard to come by. So our body has come up with natural defenses against starvation. Unfortunately, it doesn't have any natural defenses against obesity. He says overeating, but I think the problem is more complex than just overeating. So I would substitute overeating with obesity in general. So the problem is that because we don't have these natural defenses, if you look at the trend of obesity in this country over the last 10 years, we've gone from more blue to more red. And if you're Republican, you'd like this map. Well, that's not what this is demonstrating. It's talking about the fact that we're seeing more and more obesity in this country as time goes by. So it's not a problem that's solving itself or being solved even with the best efforts of a large number of people. Go to the next slide. So the question is now what? What do we do? We have a sense of the problem. How do we address it? What do we change? And there are different things you could do. You could do nothing, right? Which would put you at the risk we've talked about. I call that the ostrich maneuver, and nothing good ever comes out of that. The other options are lifestyle changes, medical management, and surgical management. So we'll go through some of these, excluding the do nothing. So lifestyle changes, what are those? Well, we're all familiar with this. It's diet and exercise. And the question is, how effective is that? Well, diet and exercise gives you variable weight loss. Is anyone that's dieted and exercised to try and lose a few pounds? No. If you look at folks 5 years out, they would have lost, 5% of people would have lost about 5 pounds with diet and exercise alone in 5 years. So what that means to me is that when you look at that BMI scale, the appropriate people that should try diet and exercise are probably folks that are a little overweight, BMI 27, maybe a BMI up to 30, because then you can lose the 2 to 3 points and get some of these comorbidities down. What are the cons of diet and exercise? Well, it requires perseverance, commitment, and you have to keep at it. You can't do it for a week or two and then go back to your usual routine because it won't work. And like everything else, there are risks involved. Depending on what diet, what choices you make in terms of exercise, obviously you can have injury, and then depending on what kind of diet you go on, you can have malnutrition to a mild degree, of course. And the interesting thing is that the body actually is designed to fight your diet. Thanks a lot, body, right? It's designed to do the opposite. The more you starve it, the lower your metabolism gets, so you don't lose as much weight from not eating. And your body actually releases hormones to make sure you're hungrier. And if you think about it, if you go grocery shopping when you're hungry, you buy half the store or more, right? If you go grocery shopping when you're full, it's a chore. You don't want to be there. And so what's different? A full stomach causes your body to stimulate your brain in a different way to adjust how your patterns are. So that's lifestyle changes. Next, we could talk about medical management. And I think medical management a lot of times comes down to medical pills. Sure, there are some you've seen on TV, but there are also others that require a prescription. And so what are kind of the results we expect with weight loss pills? If you look at a lot of what's published in the data, most people will lose about 5 to 10% of their body weight in about a year with weight loss pills. That correlates to about 2 to 5 BMI points. So if you go back again to that chart I showed you in the beginning, the appropriate person to use weight loss pills would probably be a BMI 30 to 35, because they can lose the 5 points and get their BMI under 30 and come out of the classes of obesity. Some of the cons are that you have to continue taking the pill to get the result from it. And some of these pills, unfortunately, are not designed to be taken long term. And the ones that are, you have to continue taking them to get the effect you want. Like everything else, doing nothing, lifestyle choices, and medical management, there are risks involved. And even though these aren't very common, you can have cardiac injury with certain drugs. Some drugs you can't take if you're pregnant because of birth defects, and some drugs you have to watch the liver and make sure there's no liver injury. Certainly you have to balance those risks versus the risk of doing nothing at all. Next slide, please. So what I'm going to spend most of the time talking about is surgical management of obesity. And this is really for people that their BMI has tipped over 35. We're going to talk about these different options, the pros and cons, how effective they are, and some of the risks associated with these operations. So we'll start with the lap band, which probably in the last 10, 15 years had gotten a lot of interest and has become well promoted and a lot of people are familiar with. But what is a lap band? What we do is we place a silicone band around the top part of the stomach, and we place the port that you can see there on the right side under the skin. And the two are connected with a tubing, and what we do is we inject that port with saline. It goes down the tubing and it tightens that band around the stomach. The net effect is that you have a pouch at the top part or proximal part of the stomach that catches food and then slowly releases it to the rest of the stomach. and that's designed to give you the feeling of fullness and satiety. The claim to fame for the lap band is that it's a reversible operation, and what this really means is that we can always go back in and remove the lap band if it's not successful for you or if you're having any issues with it. It has a low operative risk, it's a relatively short operation, and it has a very low complication rate, which makes it very appealing. The problem with it is that the results are variable. Some people will say that a third of people will lose weight, a third will gain weight, and a third will remain the same after a lap band. But it does show about 40 to 50% excess body weight loss in a year, and it will drop your BMI points about 10 to 15 points in the first year to 2 years. Next slide. The cons are that if you're scared of needles, this might not be the right operation for you, okay? For the first year, every month or so, you'd have to come in and have a needle inserted into that port. Now, of course, we numb the skin and we try and make sure it's as comfortable as possible, but it's still a needle going into that port. And the other concern with the lap band, or something that you need to be aware of, is that there's a high rate of reoperation with the lap band. About 50% of people will have it revised or removed in 5 years, and in some studies as high as 80% of people will have it revised or removed in 8 years. The risks include slippage. That band can slip up or down the stomach. This is usually related to bands that are too tight and patients vomiting, and so the pressure of the stomach moves that band. In addition, you can have erosion. Again, that's at a higher risk if you have a really tight band, but the band itself can erode into the stomach, requiring removal. And the last would be esophageal dilatation. If the band's too tight, the esophagus works too hard to move food into the stomach, and it can dilate and become non-functional. So all these things are risks that would then require removal, revision of the lap band. We'll go to the next slide. Next operation we'll talk about is a sleeve gastrectomy. Now, the sleeve gastrectomy is relatively straightforward. It's an operation where a portion of the stomach is removed, anywhere from 70 to 80% of the stomach. It's not reversible because you are removing part of the stomach, never to be seen or heard from again. And so the lap band, the sleeve gastrectomy, the way it functions is that the stomach that's left behind takes less food before you feel full and satisfied. And the part of the stomach that's removed releases a hormone called ghrelin, which is thought to be the hunger hormone, at least one of them. And so if you think back to diet and exercise and the fact that if you eat a little bit of food, your body fights back by making you more hungry. Well, if you have a sleeve and you eat a little bit of food and you feel full, your body doesn't have that same response. So your metabolism doesn't slow down. Your body doesn't go into starvation mode where it's trying to conserve energy. In addition, you don't have the hunger hormone that makes you shop at the grocery store and buy more than you need. So that's kind of how the sleeve gastrectomy works. It's very effective. It's a predictable weight loss pattern. Most people will lose 60 to 70% of their excess body weight. They will drop about 15 to 20 points off their BMI. And because of that, I think it's a good operation for folks that have a BMI between 35 to 45. Just doing the math, 20 points off that gets you under 30 to a safer, lower risk BMI. So those are the pros. The cons of a sleeve, because you have removed part of the stomach, your ability to metabolize iron, vitamin B is adjusted, and so you have a risk of vitamin deficiency, and it's recommended you take a multivitamin and a calcium daily to combat that. The surgical risks, because you are dissecting the stomach, you have a risk of bleeding, the staple line can leak, and you can have narrowing of the stomach. Now, these complications are readily addressable. Bleeding usually stops on its own or requires a transfusion. A leak may require reoperation to address, and stenosis may require upper endoscopy to stretch out the part of the stomach that's narrowed down. And most patients with the latter will present with nausea, vomiting, and that kind of clues you into the problem. We'll go on to the next slide. We'll talk about the gastric bypass. The bypass is a little bit more complex. It requires dividing the stomach into two separate components. The top part is the gastric pouch, which is smaller. It's designed to catch the food you eat. The second part of the operation involves rerouting the intestine. We divide the intestine a little bit ways down. We bring one limb, one part of the intestine up to the pouch, and we reattach the second part lower down. I'm going to demonstrate that because it's a little bit easier to understand. So this is the pouch here, and we divide the intestine down here, bringing one limb up here, and bringing the second limb down here and reattaching it here. What that does is that the food you eat enters the pouch, giving the feeling of fullness, and then the food tracks down this limb of intestine, but it's not seeing any digestive juices. The digestive juices come from the liver and an organ sitting here called the pancreas. So the digestive juices come down this way and meet the food down here. And that's where you start having digestion occur, and you absorb the nutrients you need along the rest of the intestine down here. So that's how a gastric bypass works. As you can imagine, the weight loss is more than you would experience with a sleeve gastrectomy, about 65 to 7% of excess body weight, and 15 to 20 points off the BMI, but leans more towards the 20 than the 15, and while the opposite is true for a sleeve gastrectomy. The risks include a greater risk of vitamin deficiency, still the same vitamins, including iron, vitamin B12, and calcium, amongst others. And so you will need to take supplementation. The second thing is dumping syndrome. Now, I listed this as a con, but some people consider it a pro, and you have to decide. Dumping syndrome is a constellation of symptoms, including feeling flushed, having an increased heart rate, and it results from food moving from the stomach into the small intestine rapidly. And it's usually found after you eat sweets, ice cream, chocolate, things like that. So some patients like the idea that after a gastric bypass, they kind of get a slap on the hand when they eat the foods they should try and avoid. So they consider that a pro. Certainly it's not a pleasant feeling, and so you can consider that a con as well. The risks are similar to a sleeve gastrectomy because we're dividing the stomach, but there are additional risks associated because we're maneuvering and moving the small intestine around. Bleeding, leak, narrowing, as I talked about earlier, but you have the potential for internal hernia where the small intestine kind of gets into these gaps that are left behind from having surgery if they reopen up. And so you can have bowel obstruction and things of that sort. The last would be ulcers, where you have the intestine attached to the stomach. So go to the next slide. So the last operation I want to talk about is the duodenal switch. It's a less common operation. People don't know about it as much, but it's a pretty complex operation involving a sleeve gastrectomy type approach where we remove part of the stomach, but also involving an intestinal bypass, much like the gastric bypass. The only difference here is the gatekeeper of between the stomach and the small intestine is preserved in the duodenal switch. It's called the pylorus, and it's at the very end of the stomach. You have the same small bowel transposition, if you will, where food goes down one tract, digestive juices go down another, and you meet further down. Let's go back to the previous slide for a second. As you can see with the gastric bypass, you have a fair amount of small intestine left over to meet gastric or digestive juices as well as the food you eat. We'll go to the fourth slide. With a duodenal switch, you have much less intestine left over, and so there's a much less period of time where you can absorb the nutrients from the food you eat. The pylorus sits about here, and with the bypass, it doesn't have the ability to control how food goes into the intestine, but with the duodenal switch, it remains there so food can track down the intestine this way, and digestive juices, again from the liver and the pancreas, can track down the limb this way, and then they meet here, and you have digestion and absorption at the end. So the duodenal switch is considered non-reversible because part of it is the sleeve where the stomach is removed, and the other part is the intestinal bypass. It's considered the big gun operation. It's more complex, and it certainly has more weight loss and has a record of keeping the weight off more than any of the other procedures. The other thing about it is because you absorb only 40% of the protein you eat and 20% of the fat you eat, the operation is designed to allow you to eat more food than the other three operations, lap band, sleeve, or gastric bypass. The effectiveness, it's the most robust operation in terms of how much weight you lose. 70 to up to really 100% of excess body weight can be lost with this operation, with BMI changes as much as 20 to 35 points, making it a really good option for folks with a BMI certainly over 50, but we start considering it seriously once your BMI tips over 45. So the cons with the operation, it's going to have the greatest risk of vitamin deficiency, as you would expect, due to how much intestine is bypassed. The other thing about it is that it results in foul-smelling farts, right? So patients will tell me, well, Dr. Ayoola, I don't know about you, but my farts don't smell good right now either. But what you have to keep in mind is that it goes beyond that. And I had a patient tell me he could kill small animals with his farts. I haven't seen him do it, but that's what he said. And so that's something just as a social thing that you need to be aware of. Most patients will experience more bowel movements. Now, the average is usually 2 to 4, and it's different for everybody because everyone has different bowel habits at baseline. But certainly with a DS, you would expect more bowel habits. The risks are similar to the other operations. However, because it's a more complex operation, there's an uptick in the percent of people that have a complication. And because the patients are usually higher BMI, higher risk at baseline, there's a slightly higher risk of complication due to that as well. Go to the next slide. So how do we've downloaded a lot of information. How do you choose what operation to go with? Well, kind of as I've focused on, the first thing you have to think about is what your BMI is, right? If your BMI is 27, then you might want to go the diet exercise route. If your BMI is 35, a sleeve gastrectomy is a reasonable option. If it's 50, you should consider a duodenal switch. But you have to go beyond that because BMI doesn't tell the whole story. The other question is what your goal is. If your BMI is 50 and you're really just trying to get down to a BMI of 35, knowing that you're still going to be classified as obese, but your risk profile is improved, then a sleeve's not an unreasonable option. So you have to think about what your goals are and what you're trying to achieve. There are people that feel like if their BMI is cold stone normal at 25, they would feel and look too skinny or unhealthy and things like that. So it's worth considering. Lastly, you have to, or thirdly, you have to look at what medical conditions you have. Diabetes is best treated with duodenal switch, then a gastric bypass, then a sleeve, and lastly, a lap band. So if you have diabetes, you might want to, even with a lower BMI, you might want to consider one of the more invasive operations rather than one that's not. If you have acid reflux, for example, you want to avoid operations like a lap band that might actually worsen your reflux. You might want to gravitate towards a gastric bypass that actually treats reflux. So those are some of the things we look at consultation, what your medical problems are, to decide what operation is best. You have to think about what you like to eat and how you like to eat. There are folks that don't mind having lots of small meals over the course of the day, and there are others that enjoy eating and want a bigger sleeve, like with a DS, so they can eat a greater volume. There are folks that like eating certain types of food, but not others. And so you have to look at what operation allows you to eat what you are naturally inclined to want to eat. If you really like ice cream, we might have a problem anyway, but you definitely want to look at whether you want to do a gastric bypass for that reason versus not. And then you have to look at how much risk you're willing to take on. Certainly, the more invasive the operation, the higher risk it is, and so that's something to keep in mind as well. And the last thing is something that's not often mentioned, but you have to look at who your surgeon is. If you go to a surgeon that does only lap bands, if your BMI is 60, they're going to recommend to you a lap band. Okay, if they do sleeves and that's all they do, if your BMI is 35, they're going to recommend a sleeve. So you have to make sure that your surgeon is comfortable performing all of these procedures and willing to talk to you and give each operation equal billing. But the most important thing is that you should make a difference and flip the switch and go from the same thing that you've been doing to something different if your BMI is not where you want it to be. So the process goes something like this. You contact us or the folks at Forest Park, and we will schedule your consultation. We'll get approval with your insurance to cover the operation, and we'll schedule you for a date for surgery. And then we're very big on making sure we get you recovered. This is a wonderful facility for doing that. The staff here is very experienced. They do wonderful work. And then it's very important that you follow up long term so we can help and guide you towards success. And I think the most important button here is the Act Now button, because this is something we all tend to put off till tomorrow, but it's something that really needs to be dealt with sooner than later. So here are some examples of our patients that have had weight loss surgery. This is a 20-something-year-old girl that had a sleeve, and this is her picture 6 months later. The patient on the right had a duodenal switch, and this is her 6-month result. And this next patient had a sleeve. We had 2 patients that had sleeves that I've put on here, and our last patient had a duodenal switch, and that's her picture about 6 months later. Now, you know, I think as regular people, we're all vain, and whoever says they're not vain has done a great job convincing themselves of that, because the rest of us all know that we all like to look a certain way and feel a certain way. And you can all see in these pictures that the smile before and after changes when people have lost the weight they've been carrying for so long. I think what's equally important is that what you notice is that a lot of the weight that's lost is usually truncal, central weight. And this is important because that's where central obesity is what really drives a lot of these medical comorbidities you see, the diabetes, high blood pressure, and things of that sort. And so this just demonstrates how people really lose that central obesity. It makes them feel better, it makes them look better, and it makes them have a longer lifespan. You can go to the next slide. So if you have any questions, I'd be happy to answer them. If you're shy like me and you want to send me an email, that's my email up there. I'd be happy to answer any questions anyone might have. Thank you. Yeah, leave it on. Yeah. Questions? Clear as mud? Well, good. Well, I'm going to hang out here for a little bit. If anyone has any questions, you can just approach me. And I also want to have one of our patients who is gracious enough to join us here, just say a few words about what her experience has been and kind of why she chose the operation she chose and what her thoughts are about weight loss in general.
The switch in November, I was 360 pounds. I'm just shy under 200. So my weight loss is around 150. Thank you. I decided to, I walked in and said, I'm okay with 360. I just want a little bit of weight off. I'll take the sleeve. And he said, you sure about that? So I wanted my food my way, and in some ways, and talked me into my BMI lowering. I was healthy. I'm 41, had no medical issues, and I thought, okay, we'll go ahead and do it. So I leaped off. I call it, I was in denial before, because I thought at 360, that is my lovely, beautiful daughter Madeline with me, who can contest to the flatulence being bad. Just to tell you, I thought I could do this. I could lose it myself. So after consulting with Weight Loss of North Texas and Dr. Ayoola, getting me in the right path of doing the switch, going through my consult, the surgery itself was, I'm not going to say it was totally easy, but it wasn't as difficult as I expected it to be. they were great enough to walk me through each and every step and tell me what was coming up next. And through the procedure, I didn't have very many complications other than when I decided to eat chocolate, it didn't work. So again, it's just keeping yourself up at knowledge. I will tell you that you're right about, trying to look a certain way and feel a certain way. I've always loved fashion and always wanted to look like one of those cute little girls, but I take it out as a big girl in my purses and my shoes. And now you do feel better. You can wear clothes. You can feel a little bit better about yourself and kind of go through life with a little bit more spring in your step. And if you'd have told me this back in November, that this is how you were going to be, I wouldn't have thought my weight would have really caused that much of a difference in my life. So I'm still healthy and have enjoyed my switch, as I call it, and have enjoyed the staff that has walked me through the process and been there every step of the way, and especially this man here. So, any questions for me?
Thank you.
Good. Madeline, you're next. No, I'm kidding.
Thank you. So we have some snacks, food and drinks in the back if anyone would like to help themselves. Again, as I said, I'll kind of hang out and be happy to talk to anyone one-on-one if you have any questions or want to hear more about what we talked about. Thank you all for coming.